Thank you very much. It's my honor and pleasure to join this prestigious Congress. I would like to thank the organization committee and the moderator for this kind introduction. So I will move the slides. Okay, so my objective today is actually to how can I go back? So my objectives today actually is to go over current diagnostic risk stratification and approach for patients with Hodgkin lymphoma, and to review and discuss current knowledge about regimens that we recommend for upfront treatment, review potential long-term complications, as well as to review novel agents that have been used in upfront treatment. So we all know that Hodgkin lymphoma is constitute around 7% of children with cancer, and it is only constitute of around 1% of childhood cancer death in the United States. There is a high chance of cure in patients with Hodgkin lymphoma. However, these are associated with long and short-term toxicity. So the goal of treatment in patients with Hodgkin lymphoma is usually to continue maintaining high survival rate, as well as to attempt to reduce therapy-related long-term toxicity. Just to go over the pathology of Hodgkin lymphoma, we classify them into classical Hodgkin lymphoma and neurolymphocyte predominant Hodgkin lymphoma. Both are associated with lymphadenopathy. However, Hodgkin lymphoma are classically associated with red Sternberg cells that are CD15 and CD30 positive, whereas neurolymphocyte predominant Hodgkin lymphoma usually associated with popcorn cells that are CD30 and CD15 negative. If we look at the incidence of Hodgkin lymphoma across pediatric and adult age, we can see that from series data that Hodgkin lymphoma is start usually at the ages of between 5 and 9 and continue along the years. However, there is 2 peaks early in life and later on. Data from Saudi Arabia, as recently published in the Cancer Incidence Report, we can see here that the annual standardization rate of cancer in children is slightly higher than in Western regions. So this is something that to be considered for future studies. To evaluate patients with Hodgkin lymphoma, after history and physical examination, excisional biopsy is strongly preferred. Fine needle aspiration usually underdiagnose these type of tumors. Other evaluations include laboratory investigations, PET scan, X-rays, and echocardiogram, just to assure adequate cardiac function before anthracycline-based chemotherapy. The principle of staging in Hodgkin lymphoma in pediatric is based on Arbor staging system, where staging is ranges from stage 1 to 4 based on the location of the lymph node and whether it is above and below diaphragm. Also part of the staging system is to assess the bulkiness of the disease, and the definition as per Children's Oncology Group is bulky disease is more than 1/3 of the thoracic diameter, or peripheral lymph nodes more than 6 centimeters. Also, B symptoms is very important in risk stratifying patients, where patients who have fever, night sweats, or drenching or weight loss are considered to have B symptoms. Based on that, different consortium risk stratify patients to either low, intermediate, or high risk, and you can really see that there is no consistent risk stratification between cooperative group. You can see here Euronet usually consider stage 2B, 3, 4 as high risk, whereas in the Children's Oncology Group, stage 3A is an intermediate risk, and other important prognostic factor like ESR and disease bulk is being considered. Just to look at the outcome of recent cooperative group outcome in treatment of children with Hodgkin lymphoma, we can see that we are being successful in treatment of Hodgkin lymphoma in general. So overall survival, you can see it's touching the 100%. However, there is substantial amount of radiation therapy that are delivered to patients with Hodgkin lymphoma. It ranges between 30% and 60% in high-risk group. And you can see that, that most of this therapy are intracycline alkylator-based chemotherapy, which is associated with both long and short-term toxicity. So NCCN came up with the guidelines that are recently published, and the last version of it usually recommends for low risk to be treated as per-unit chemotherapy, 2 cycles of OIBA, plus minus radiation for based on slow responders. Other chemotherapy for consideration is as per adult, the ABVD regimen. For intermediate and high risk, both regimens as per the Euronet and Children's Oncology Group are preferred options, and ongoing clinical trials is always recommended for those group of patients. Very important to know that over time, children oncology groups and other groups are successfully able to reduce both doses of radiation as well as the field of radiations. So you can see historically the treatment was involved regional radiation therapy, and this came down to response adaptive radiation therapy, where patients who responded to treatment, they don't need to receive involved site radiation, where some bulky disease might receive radiation. Why is that important? Because the long-term effect. We can see that this is data for patients of around 3,000 patients followed up by the childhood cancer survival group. They really show that high risk of development of long-term toxicity for patients, particularly who receive anthracycline, alkylators, and radiation therapy. More the dose of anthracycline and radiation therapy, more the risk of long-term complication. This being also observed that the new contemporary studies showing that there is reduction in this type of complication because of response adaptive therapy. Just shifting gears to novel therapies, we know that classical Hodgkin lymphoma expresses CD30, and it is amenable for target antibody-based targets. So brentuximab is an immunotherapy that targets CD30 in classical Hodgkin lymphoma. Data from adults show that using brentuximab combination with chemotherapy, it resulted in higher survival rate, both in progression and overall survival, in high-risk group. Similar study was done in pediatric using combination of brentuximab with OIPA Cobadag backbone, and as we can see that it resulted in higher event-free survival and overall survival. So this led to a study, a randomized controlled trial by Children's Oncology Group to look at incorporating brentuximab into the backbone of the ABV-EPC, which is a standard chemotherapy in a high-risk group of patients. It is a one-to-one randomization for patient age from 2 to 21, and high risk here is defined by patients who have stage 2B with bulky disease, stage 3B, 4A, and 4B. And they receive response adaptive chemotherapy, where they had interim analysis by PET scan after 2 cycles. And those who are slow responder receive radiation endotherapy, and all those who have large mediastinal mass at diagnosis will receive radiation therapy. The data is published last year, and it showed that brentuximab resulted in improvement of overall survival and event-free survival, and reduction of events by more than 50%. This was true across all subgroups, so age, stage, whether it be symptoms or no, bulky disease. However, bone marrow involvement was not really shown any difference whether patient receives brentuximab or no. So this is a landmark paper that resulted in a new standard of care in treatment of children with Hodgkin lymphoma. Very important to know that this also was true for both slow responder and rapid responder. So brentuximab was the winner in this randomization. In terms of toxicity, there was no different toxicity between the two arms. Particular toxicity related to brentuximab, which is peripheral neuropathy, was comparable to the brentuximab arm and the standard arm. So the other immunotherapy that are being tested in Hodgkin lymphoma is PD-1 inhibitors. As we know that Hodgkin lymphoma really express high level of PD-1, and this is mainly because of amplification of chromosome number 9, and this has been shown to be effective in relapse, and it's been tested recently in upfront setting. So basically, PD-1 inhibits the T-cell engagement, and so by inhibiting this, will activate T-cell to engulf and engage in classical Hodgkin lymphoma tumor cells. So in a plenary session this year, SWOG 1826 study asked to randomize patients to two arms, nivolumab, which is PD-1 inhibitor, and brentuximab, with a backbone of AVD, which is an adult-based backbone. For the first time, pediatric age group, 12 to 17, were included in this study, and they received 6 cycles of chemotherapy, followed by assessment end of therapy, and those who have PET positive end of therapy, they might receive radiation therapy. So the results showed that nivolumab arm resulted in higher event-free survival. This is a 12 months progression-free survival compared to brentuximab arm. Nivolumab across all subgroups was showing that it is effective. Stage, age, and whether this patient have B symptoms or no. And in terms of overall survival, it is near 100% in both arms, indicating that the retrieval rates for those patients who relapse is very high. In terms of side effects, we can see that it is comparable between the two arms. However, the neutropenia is higher in the nivolumab arm, where it is lower in the brentuximab arm, and this is maybe because of in the brentuximab arm, the G-CSF was required for this group of patients. In terms of peripheral neuropathy, was slightly higher in the brentuximab arm as expected. So if you want to compare these two recent high-risk group study together, we picked the winner of the AHOD 1331, which is the brentuximab APC arm, and compare it to the recent SWOG study. Very important to know that the age group is different. So pediatric treat patients from age 2 to 21, where SWOG you treat patients age 12 and above. The risk and staging are different between the two groups. In terms of brentuximab dosing, it's higher in the SWOG study compared to the AHOD 1331. Whereas the anthracycline is nearly around 250 to 300, which is not a much big difference. In terms of peripheral neuropathy, is comparable to the both group, and indication of radiation therapy in the AHOD study is based on the interim response. So after 2 cycles, if you are slow early responder, they will receive radiation, or if you are large mediastinal mass, end of the therapy. Whereas in the SWOG study, it is based on the end of the therapy response. The percentage of radiation therapy received in AHOD 1331 patients is around 57%, whereas less than 1% in the SWOG study, which is a very substantial reduction in radiation therapy in those group of patients. Very importantly to know that chemotherapy frequency in the COG backbone usually is more frequent, so they need to come day 1, 2, 3, and 8. So if we take 5 cycles, the cumulative amount of chemotherapy visits per patient is around 20, versus every 28 days in the SWOG study, which is day 1 and 15, and cumulative chemotherapy visits around 12 days. For the COG study, the 3 years event-free survival and overall survival is 92 and 99%, where for the SWOG study, we just have the 12 months event-free survival and overall survival, and we're looking forward to have a longer-term follow-up. Also, children oncology group are now ongoing new active studies, AHOD 2131, and basically another study trying to harmonize treatment between children and adults. So they are using the ABVD backbone in both arms, whereas in the favorable risk group, if they are rapid early responder, they will be randomized to 2 cycles of ABVD or immunotherapy consolidation with brentuximab and nivolumab. For the slow early responder, they will be randomized to escalating chemotherapy, escalating BIACOP, or to be randomized to 4 cycles of immunotherapy. Whereas for those unfavorable risk, they will be induced by 2 cycles of ABVD, and based on response, whether they will receive 4 cycles of AVD or immunotherapy-based regimens. And for those who are slow early responder, they will be randomized to chemotherapy escalation with BIACOP versus immunotherapy escalation. And we'll be really wanting to hopefully see the effect of immunotherapy consolidation in this risk group. So for us, what is the criteria to select standard of care is one want to select most effective treatment and least toxic chemotherapy, most effective augmented therapy with to the high-risk group or those who are slow responder, and regimen that has the least amount of radiation therapy. So to conclude, risk and response adaptive therapy lead to improvement in outcome of children with Hodgkin lymphoma. A novel combination of chemotherapy further improved outcome in high-risk group. There are significant reduction in radiation therapy doses and field in recent studies. Long-term follow-up is needed to evaluate the outcome of immune therapy-based regimens. I think harmonization with adult chemotherapy is feasible, and there is ongoing children oncology group trial that try to extend this to a low-risk group. Of course, long-term follow-up for those groups is mandatory to assess both side effects and patient-reported outcome. In adult-based or adult-inspired chemotherapy, they usually don't use steroids, cyclophosphamide, and etoposide, which is very important toxic medication in both long and short terms. As we heard in AML, cardioprotective agents is very important to be considered in patients who receive anthracyclines. And hopefully in the future we'll be eliminating radiation as much as possible, because it is really associated with long-term toxicity in this group of patients. By this, I would like to thank you, and looking forward to hear from question end of this discussion. Thank you very much.